Hello, and welcome to today's webinar, Research Update, the latest news about psoriasis and psoriatic arthritis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane, and the dial-in information will be displayed. Questions received prior to today's webinar will be addressed by our speaker, dermatologist Dr. George Martin, during the Q&A session following his presentation, which was recorded yesterday. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, Amgen, Bristol-Myers Squibb, Janssen Pharmaceutical Companies of Johnson & Johnson, and Novartis for their support of today's webinar. Since some of you may be new to the Foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation, NPF, has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan in July 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over 5 years, NPF will focus on achieving 3 goals: lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes, to date, NPF has funded over $28 million in grants and fellowships. This includes almost $3 million in grant and fellowship funding announced July 2nd. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant, which are new to the Foundation. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged a definition of prevention to better guide the proposal development, and that's how it expanded to include disease relapse and comorbidities. NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. This could significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 Npf research efforts that you can be part of. Launched in 2015, the Npf Corona National Psoriasis Patient Registry is the largest independent observational registry of psoriasis patients in the U.S. The registry collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 12,700 patients enrolled at more than 270 sites across the country. Your dermatologist may be enrolled as an NPF Corona National Psoriasis Patient Registry site. Not sure if they are? Ask. If they're not, encourage them to join. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or guttate psoriasis, and be a candidate for office or home phototherapy. There is no washout of topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. Citizen Scientist is a platform where you, as a patient, answer survey questions which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The Npf Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we would appreciate you sharing your experiences with us. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual or live team NPF events, such as Stamp Out Psoriasis, walk, or cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. Now I'd like to introduce you to our speaker, dermatologist Dr. George Martin. Dr. Martin is a practicing clinician, dermatologist, clinical investigator, and internationally recognized speaker in private practice in Kihei, Maui, Hawaii, whose clinical interests include psoriasis, atopic dermatitis, cutaneous oncology, and connective tissue disorder diseases. Dr. Martin is founder and program chairman of the internationally recognized dermatology meeting Maui Derm Advances in Cosmetic and Medical Dermatology, which is a professional meeting for dermatologists and other healthcare providers. Dr. Martin is also co-founder of Rheumatology Winter Clinical Symposium. His interest in evidence-based medicine also led to creation of the Delphi-based consensus conferences in psoriasis, acne, atopic dermatitis, and rheumatoid arthritis. Dr. Martin is also contributing editor to the Journal of Clinical and Aesthetic Dermatology and Skin Med Journal, as well as the Yearbook in Dermatology. He is a medical board member of the National Psoriasis Foundation, which provides clinical direction, treatment guidance, and provider education oversight on behalf of the Foundation, along with supporting advocacy efforts to increase safe and effective treatment. With such a background, Dr. Martin is a perfect speaker to provide an update on psoriasis and psoriatic arthritis. It is my honor to welcome Dr. George Martin.
Thank you, Bev, for that kind introduction, and I'm looking forward to chatting with you about the latest in research pertaining to psoriasis and psoriatic arthritis. We live in very exciting times, and I think we are headed the way of finding a cure to psoriasis and psoriatic arthritis, and we certainly have amazing new drugs that will help control the disease state. So let's just jump right in, and these are my disclosures. I work with many of the companies that do research and development on drugs used to treat psoriasis and psoriatic arthritis. So today what I'd like to talk about are a couple of key points in the arena of psoriasis and psoriatic arthritis. And one of the questions we ask is psoriasis and psoriatic arthritis an autoimmune or an immune-mediated disease? And we'll talk about some of the data. What is the impact of systemic inflammation associated with psoriasis on an individual's longevity? And then we'll end up with clinical research regarding new therapies coming our way and new indications for existing therapies. So psoriasis affects approximately 7 million people in the United States, with approximately 250,000 new cases reported each year. We estimate that 1.5 million individuals in the United States have moderate disease, which is 3 to 10% of the body surface area, or severe disease, which is over 10% of the body surface area involvement. We also recognize that the initial presentation of psoriasis is often between the ages of 15 and 35 years of age, with approximately 10 to 15% of patients younger than 10 years of age when they present with psoriasis. And with regard to patients with psoriasis, one of the noted comorbidities is psoriatic arthritis, which can occur in anywhere between 20 and 30% of patients who have psoriasis. And it usually starts about 8 years into the disease state, but it also continues. And you could be 20, 25 years into your psoriasis and still develop psoriatic arthritis. So you have to keep a watchful eye on that. So the first question is psoriasis an immune-mediated or autoimmune disease? And why is this important? Well, the question, is psoriasis a primary autoimmune disease or secondarily evolving into autoimmunity as observed in other chronic inflammatory conditions, is being asked at the basic science research level. And this is really important. And why it's important is that we are looking for the Holy Grail, and we're going to talk about that. So the excitement about this, an answer to this question, arose from a paper in 2014 where they identified, we call an antimicrobial peptide, which is LL37, that's found in your skin and defends you against various bacteria and fungi. and noted that it was found to be a T cell autoantigen in psoriasis. In other words, your T cells were reacting against this antimicrobial peptide found in your skin, found in everyone's skin. So this really sparked a great deal of thought. And the question begets is, why is this important? And it's important because if we find the autoantigen, in other words, that protein, that molecule that's responsible for triggering psoriasis and psoriatic arthritis, we will be well on our way to finding a cure. And so this autoantigen, we believe, is the initiating event in psoriasis and psoriatic arthritis. And if we're able to identify it and substantiate it, we're able to figure out biomarkers that can be obtained from either blood samples or tissue samples to help us diagnose and monitor disease activity. Additionally, it may provide a target for therapies to allow for early intervention in the course of the disease. So finding this autoantigen, this protein that triggers autoimmunity, has been what we refer to in psoriasis and psoriatic arthritis, the quest for that holy grail. So let's talk a little bit about autoantigens and autoantibodies. So clearly psoriasis shows an autoimmune pathomechanism. I mean, we know it to be, and it is listed as an autoimmune disease, but until 2014, we didn't know what the exact target was for this autoimmunity and what maintained and drove psoriasis. So to date, we've uncovered 4 autoantigens in psoriasis that may be drivers of the disease, both initiating and driving the disease. I just mentioned LL37, which is an antimicrobial agent. Melanocytes have a particular protein, ADAMTSL5. There's lipid antigens that are created by this enzyme, PLA2G4D, and then keratin 17. So let's break this all down. So this wonderful review paper came out in 2020 and really addressed these 4 autoantigens and autoantibodies. And our current thinking is this, and this rather complex slide really starts on the left-hand side of the screen with either plasmacytoid dendritic cell or myeloid dendritic cell. And they're the ones that pick up the autoantigen. They pick up the signal. And in this case, it's LL37 or ADAMTSL5. And what we see is they initiate this incredible inflammatory process that involves eventually the proliferation of keratinocytes, a lot of inflammation. And then you have the perpetuation and maintenance of disease, kind of a loop or cycle, all triggered by what we feel are autoantigens. In this case, we've listed L37 and ADAMTSL5. So these are the 4 we mentioned. Most importantly, what we have identified are autoreactive T cells. These are T cells that are primed, and they identify these 4 antigens. And they were found in a number of patients with moderate to severe plaque psoriasis. So the discovery, particularly in 2014, of autoantibodies against L37 and eventually ADAMTSL5, and their strong association with psoriatic arthritis, suggests a potential role for these autoantibodies in the pathogenesis of psoriatic arthritis. So let's take a look at where these autoantigens can be found. We've all mentioned LL37, which is this antimicrobial peptide that when it binds to antimicrobials in this sort of neutrophilic net can be an autoantigen. Here is the melanocyte-associated ADAMTSL5. Up here is the keratin 17. And then over here is the enzyme that's generated by mast cells that cleave lipids or fats. So let's do a deeper dive into what these are all about. So as I mentioned, L37 is an antimicrobial peptide, and it complexes with DNA and RNA, self-DNA and RNA originating from these neutrophilic nets. And when L37 DNA complexes, it initiates an inflammatory signal from these dendritic cells found in the dermis, and then they become activated. And when they're activated, they express tumor necrosis factor, IL-12 and 23, and this really drives the entire inflammatory pathway in psoriasis. So this is believed to be one of the autoantigens that are found normally in your skin that suddenly, in patients who are predisposed, they start recognizing this as a foreign molecule. ADAMTSL5, this is derived from melanocytes, and it results in the activation of intraepidermal CD8 cells, which are inflammatory cells, and increased amounts interferon gamma and IL-17, potent drivers of psoriasis. So we know there's an association there. And then we talk about keratin 17 found in the epidermis. And it turns out that the surface M protein from the strep bacteria that we find in strep throat and keratin 17 is found in psoriatic skin lesions. There's a strong association and may explain why individuals who with strep throat can really develop guttate psoriasis, where psoriasis just explodes. So it turns out keratin 17 expression is found in psoriatic lesions, but not healthy skin. Yet it's considered the hallmark of psoriasis. It turns out that cytotoxic T cells reactive to the surface M protein from strep may also recognize keratin 17 by what we call molecular mimicry. In other words, your immune system is unable to distinguish that little surface protein from strep bacteria and keratin 17, and this can lead to autoimmunity, much the way we see in strep triggering rheumatic fever and rheumatic heart disease and joint disease and brain disease. So there's a tie-in here with strep. And then lastly, the psoriatic mast cell generates these lipases that cleave fats. And it turns out that psoriatic mast cells are a major source of this enzyme that generates these antigens derived from lipids, which can be recognized by Langerhans cells, and in turn activate lipid-specific T cells. So this can be another driver of psoriasis. Again, these are all involved in the generation of autoantigens that trigger the immune system and cause inflammation. So what's the evidence for IL-37 at DAMPSL5? Well, Frasca and colleagues first demonstrate elevated levels of carbamylated anti-IL-37 antibodies in psoriatic arthritis and to a lesser degree in psoriasis patients. And it turned out that both antibodies to these molecules were found in the synovial plasma very early in psoriatic arthritis and even 3 to 10 months after the diagnosis. And this is an indication that autoimmunity against this molecule is really, really important in both the IL-37 and DAMPSL5. So could these be biomarkers? Well, when they looked at these antibodies against these molecules, it correlated clinically with the clinical activity of psoriatic arthritis, and elevated levels of DAMPSL5 antibodies were specifically increased in psoriatic arthritis patients and correlate with disease activity. So we not only have identified autoantibodies, but it appears that they correlate very well with psoriatic arthritis. So the evidence for psoriasis and autoimmunity, these findings of autoantibodies against 4 psoriasis autoantigens, there is a genetic association with HLSC S0602 with some of these autoantigens. And we can think about this as genetically predisposed individuals with certain environmental triggers may in fact develop psoriasis. So you need a genetic component. So what we postulate is that the disease onset of psoriasis and psoriatic arthritis and the activation and polyclonal expansion of T cells is introduced by these super antigens like a strep M protein or skin trauma we call Kebner phenomena. And what that does is it results in the maintenance of the disease phase. In other words, this trauma or infection can trigger autoantigens of the skin that are then recognized by your own T cells, and you become reactive to these components of your skin. So this is the current postulation. And so we're really moving in a very positive direction and figuring out the triggering seminal events that drive psoriasis and psoriatic arthritis. And this brings us one step closer to a cure. This is what we postulate. What's missing? What's missing is a complete understanding of the initial mechanism that enabled the breakdown of tolerance in genetically susceptible individuals. Like, why should we suddenly develop antibodies against proteins normally found in our skin? So this is where a great deal of research is being undertaken. And complicating the matter a bit is that these antigens, IL-37, DAMPSL5, and the lipase, PLA-G4D, is restricted T cells are not seen in all psoriasis patients. So the fact that it's not seen in all psoriasis patients may be that there are other autoantigens out there, but certainly this is a great starting point in identifying how this story unfolds in our quest for a cure. So now we are going to cover the impact of psoriasis on longevity. What we know about psoriasis is that it is a systemic inflammatory disease. It's not just a skin disease. And when we look at mortality curves, we find that psoriasis patients compared to age-matched controls with similar comorbidities have a 5-year less life expectancy because of the systemic inflammation. And specifically, when we look at those individuals with severe psoriasis, patients with more than 10% body surface area involved, that there's somewhere between a 1.5 and almost twofold relative risk for heart attacks, strokes, death from cardiovascular disease, MACE events, which stands for major adverse cardiovascular events, that's heart attack, stroke, and sudden death, diabetes, and chronic kidney disease. So we understand that if you have severe psoriasis, more than 10% of your body surface involved, that you are at increased risk for all of these severe and life-threatening issues. What we've also learned is that the inflammatory pathways in psoriasis are also found in the arteries of our body. And so there's this both psoriasis and inflammation of the arteries, particularly coronary arteries and atherosclerotic disease and arteries that course through the brain. The inflammation present in psoriasis is also found within the vessel wall, leading to clotting, narrowing, we say thrombosis, another name for clotting. And so cardiovascular diseases and even the blood flow to the kidney are all impacted by psoriasis. Now, for those of you who want to take a measure of how much body surface area you're affected by your psoriasis, your hand represents 1% of your total body surface area. So when you go around and figure out how much psoriasis you have, basically one hand, your hand is 1% of body surface area when you do that measurement. And of particular importance, patients with greater than 10% body surface area are at higher risk for death. And so this was a study from a United Kingdom primary care database, in this IHOPE study where they looked at the outcome of psoriasis and death. And what you can see, the little green dots represent those patients who have 10% or greater body surface area involvement with psoriasis. And it is a predictor of earlier death compared to individuals with lesser psoriasis. And even when you adjust for age and sex and you fully adjust it, or even just take the raw data, in all cases, having greater than 10% body surface area is a predictor for death. And so it really behooves us to, both I as a clinician and you as a patient, to introduce therapies in your body for severe psoriasis that will cut down and control systemic inflammation. So speaking of which, we have these incredible therapies, but what I'd like to talk about are new therapies in psoriasis and psoriatic arthritis. So I started treating psoriasis patients when I was doing internal medicine back between 1985 and 1988, and then became a first-year dermatology resident in 1988 at UCLA after doing internal medicine. And back then we had light booths and tar and methotrexate and cyclosporin. And in 2004, we had our first biologic agent come into the field of psoriasis with etanercept. And then we had these milestones where in 2009, we have IL-12 and 23 inhibition. In 2014, we have our oral PD-4 inhibitor, Apremilast. In 2015, we have the introduction of the IL-17 inhibitors. And then in 2015, then finally in 2017, we have these IL-23 inhibitors. And the development of these drugs really told us a great deal about the pathways in psoriasis and how to block them to mitigate the disease. So we understand through intensive research and the response of our patients to these medications that we have this inflammatory cascade in psoriasis involving tumor necrosis factor, alpha inflammation, and IL-12, 23, and the role of IL-23 specifically, and the role of IL-17. And so we have developed therapies that inhibit the action of these molecules. And you can see we have a host of drugs to stop this inflammatory cascade. And we've built upon this with this recognition that the primary drivers in psoriasis is this IL-17, IL-23 axis. And we certainly know the role of TNF in also promoting inflammation. We also recognize that psoriasis therapy is complex and it involves topicals, systemic therapies, oral systemics, and lights, particularly UVA, UVB, and narrowband UVB and PUVA. And we use these in conjunction with one another. Even the best biologic agent does not completely treat 100% of psoriatic lesions. Although newer medications, we're finding as many as 50, 60% of patients will achieve complete body clearance. That still means that you have to treat the other parts of the body that did not respond. And so we basically mix and match these therapies, but I think for patients with moderate to severe disease, we really start out with either biologic agents or all systemics. So let's talk briefly about IL-17 inhibitors because there's some very new exciting data that have come out recently. We know that secukinumab, ixekizumab, brodalumab have been on the market as early as 2015, but now we have a new molecule entering this IL-17 inhibitor category in bimikizumab, which has not been yet approved, but we have some very powerful data that has just come out. So as a group, we know that IL-17 inhibitors are fast-acting. They're very powerful drugs with excellent efficacy, that they're effective in treating psoriatic arthritis, and the current data shows that they're equivalent to the TNF inhibitors for most aspects, which include peripheral and axial disease, and inhibition of progression of joint destruction. There are also studies on special areas where IL-17 inhibitors are very effective in treating scalp psoriasis, genital psoriasis, palmoplantar psoriasis, and nail disease. And important caveat with these inhibitors to avoid patients with inflammatory bowel disease like Crohn's and ulcerative colitis, because it can trigger a flare in these individuals. So when we target this IL-17 family of cytokines, we're targeting these what we call homodimers and heterodimers, and you can see them here listed in the center. So over on the left, we have ixekizumab and secukinumab, which are very specific for inhibiting the IL-17A molecule and very effective wherever IL-17A homo or heterodimer is present. We can see brodalumab blocks the receptor, so it inhibits all of these. And more recently, we have bimikizumab, which not only inhibits the IL-17A, but also inhibits IL-17F. And by inhibiting F, it appears it gives this molecule a real boost in efficacy. So let's take a look at the recent data. And there we have bimikizumab. So recent head-to-head trials with bimikizumab were against adalimumab, which you know is Humira, secukinumab, which you know is Cosentyx, and ustekinumab, which you know as Stelara. So these are head-to-head trials. And those head-to-head trials were recently published in the case of bimikizumab against adalimumab, which is Humira, in the New England Journal of Medicine. And what we found was this. When you compare bimikizumab against adalimumab, note that when we talk about a PASI 90 response, which is 90% clearance, that at week 16, almost 87%, a little bit more than 87% of patients given bimikizumab achieved a PASI 90 score compared to 47% with the adalimumab. And then at week 24, that improved. And note that bimikizumab is given every 4 weeks, so one shot at baseline and then every 4 weeks. And when you switch it to every 8 weeks, it still maintains a high level of efficacy. And here you can see measured out at week 56 for bimikizumab, whether you use it every 4 weeks or every 8 weeks, you have over 80% of patients achieve a PASI 90. And when you look at investigator evaluations of clear or almost clear on the global assessment, over 80% of patients are either clear or almost clear using bimikizumab compared to almost 60% for adalimumab. What's also impressive when you look at PASI 100s, that's complete clearance with this. At week 16, roughly 2/3 of patients achieve it, that level of clearance compared to only about 1/4 of patients with adalimumab. And then when you take those patients and you keep treating them out to a year, again, upwards of 2/3 of patients achieve a PASI 100 score, which is really quite remarkable. When we compare it to secukinumab, so bimikizumab inhibits IL-17A and F compared to secukinumab, which is just an IL-17A inhibitor. Both are very powerful drugs. And here you can see that when you look at PASI 75 and clear and almost clear scores, they're very high level of clearance. But when you really set the bar a little higher and you talk about PASI 90 and 100 scores, this is where bimikizumab has a higher level of clearance. In the case of PASI 100 scores, you can see just under 50% of secukinumab patients achieved it at about 48 weeks. And then upwards of 2/3 and almost 3/4 of patients in the bimikizumab group achieved that complete clearance. And we looked at PASI 90, again, you can see bimikizumab outperformed secukinumab. So apparently the addition of the IL-17F inhibition along with IL-17A adds a little bit of a boost to bimikizumab compared to secukinumab in this comparator trial. One of the signals that was identified was an oral candidiasis signal in the bimikizumab group with just under 20% compared to 3%. We know that anytime you hit IL-17, you will quite possibly develop a candidiasis signal. And so when we looked at that, while bimikizumab was not involved candidiasis, it was in a minority of patients. And generally, it was a one-time occurrence of oral candidiasis. And vulvovaginal candidiasis was not seen. So the take-home points on bimikizumab, it's not yet approved, but it's completed its pivotal trials. It is more effective than adalimumab, which is Humira, ustekinumab, Stelara, and secukinumab, in achieving PASI 100 scores with approximately 60% of patients achieving complete clearance. It is a rapid onset of action. It's an injection every 4 weeks, which can be adjusted to every 8 weeks if the patients sustain a good clearance. And the data show us that the response is sustained over a year. Most importantly, when we look at safety signals, we found an oral candida signal that was generally greater than what we saw with the other IL-17 inhibitors in the range of 15 to 20% of patients, but these were usually one episode and managed with conventional anti-candida regimens, very straightforward to treat, and generally there was no vulvovaginal involvement. We're looking forward to having bimikizumab join our therapeutic arena, and we're excited to have it there for patients who really are looking for, again, a high-performance drug. So over the last few years, we have these 3 new anti-IL-23 antibodies, guselkumab, which was approved as in 2017 as Tremfya, tildrakizumab approved in 2018 as Ilumya, and risankizumab approved in 2019 as Skyrizi. And these are really long-acting drugs. Usually, in case with Tremfya, it's every 8-week injection. With Ilumya and Skyrizi, it's every 12 weeks. And joining them, pending approval, is mirikizumab, which at week 16 in their pivotal trials demonstrated non-inferiority to secukinumab, but at week 52 proved itself superior to secukinumab. So we're looking forward to another player in this domain, and just to let you know, it's in the wings. Specifically in the mirikizumab versus Cosentyx at week 16 and week 52, we noticed that mirikizumab and Cosentyx secukinumab were comparable as far as clearing or almost clearing PASI 90 and 100 scores. But when you went out a year, we noticed that mirikizumab had a slightly better performance when compared to Cosentyx. So this is a drug that performs and continues to perform over time. And in fact, as you go out to 1 year of therapy, it outperforms Cosentyx. So new therapies for pediatric psoriasis, and just as a general reminder, remember that initial presentation of psoriasis is often between the ages of 15 and 35 years of age, with roughly 10 to 15% of patients developing psoriasis younger than 10 years of age. So currently approved biologics for psoriasis in children include Enbrel, etanercept, for children 4 years and above, Stelara, which is ustekinumab for children 6 years and above, ixekizumab, which is Taltz, approved for children 6 years and above, and secukinumab Cosentyx, approved for plaque psoriasis for children 6 years old and above. So this is very exciting. These are all biologic agents. And let's just take a brief look at some of the newer approvals. So the recent approval of ixekizumab, which is Taltz, for children 6 to 18 years of age. Let's take a look at the data. In their comparator trials, primary study design was ixekizumab compared to placebo, and there was dose-based randomization. And the European protocol called for ixekizumab given every 4 weeks, not only compared to placebo, but compared to etanercept. And so here's the dose ranging regimens. And again, it was weight-based dosing, ixekizumab versus placebo versus etanercept. This is a very busy slide, but this is the way it was broken down. Your dermatologists will be very familiar with these dosing, and particularly those with children who may be seeing a pediatric dermatologist. For those of us who treat adult and pediatric psoriasis, we're all very well versed with the dosing. And what we can see with regard to PASI 75, almost 90% of patients at week 48 achieved a PASI 75 compared to only 25% for placebo. And then we talk about PASI 100. Over half the patients achieve PASI 100 at week 48. So this is very exciting that we have this very powerful molecule, very safe molecule for the treatment of psoriasis in children, age 6 to 18. And when you compare it to etanercept, which has been around for quite a while and has a very wonderful proven track record, now we have a more powerful entry into the field of psoriatic disease. And you can see here at week 12, 63% of patients with etanercept, which is Enbrel, achieved a PASI 75 compared to 84% with the ixekizumab. And then when you look at PASI 100, you can see over 60% of patients on ixekizumab given every 4 weeks cleared 100% of their skin compared to 17% with etanercept. So if you're doing great on etanercept, I would encourage your child to stay there. But if the results were not what you'd hope, we certainly have another comparator trial to prove the efficacy of ixekizumab compared to etanercept. Secukinumab, another IL-17A inhibitor, has been approved for pediatric patients between the ages of 6 and 18 years old. And the pivotal trials looked at secukinumab low dose versus high dose. It was adjusted on if the patient was under 50 pounds, was roughly 25 kilograms, got a lower dose of 75 milligrams. If you were basically between 50 pounds, 110 pounds, you got a 75 milligram dose in the low dose. And then anything above that got 150 milligrams. And then compared it to the high dose, where we saw 75, 150, and 300 milligrams. And so what was found in this trial that involved low and high dose and individuals, children, with significant psoriatic disease, with 2/3 of them being moderate and 1/3 being severe. And these are children that had psoriasis on the average of about 4 years. And they looked at different weights, categories, and different dosing schedules. And what they found was that whether the children received low or high dose, they really did quite well at week 16, with 90% of patients achieving a PASI 75 and PASI 100 complete clearance. Notice almost upwards of half to almost 2/3 of patients achieved a 100% clearance. And in this case, the over 60% PASI 100, note that was even with the low dose. So we understand that you can use low dose secukinumab and achieve some very nice clearance. That's complete clearance between 6 and 18 using secukinumab at lower doses. And here we can see the safety profile, which is very strong and certainly was comparable between treatment arms and consistent with the known safety profile of secukinumab. So there were no surprises when you began treating children between 6 and 18 years of age. So again, a very safe molecule, very powerful molecule to use in children, along with ixekizumab. So the current recommendations are weight-based dosing. If the individual between the ages of 6 and 18 is under 110 pounds, 75 milligrams is the dose. Over 110 pounds, you can use a 150 milligram dose. And you can see that to start, the child received dosing once weekly for 5 weeks and then once monthly thereafter. So let's talk about apremilast that's well known and has been approved for some time now for the treatment of moderate to severe psoriasis. As you know, apremilast is an oral phosphodiesterase 4 inhibitor. It's a pill, and it was approved back in 2014 for the treatment of psoriasis and psoriatic arthritis. And I'll talk a little bit about its mechanism of action, which is to turn off these inflammatory cytokines and increase the anti-inflammatory cytokines. It turns out that inside your cells, there's a balance between cyclic AMP and AMP. Cyclic AMP at high levels is a good thing inside skin cells. Phosphodiesterase 4 breaks down cyclic AMP into AMP, there you see in red. So when you inhibit PDE4 with apremilast, what happens is you decrease the inflammatory cytokines and you basically calm the inflammation down in psoriasis, and then you increase the levels of anti-inflammatory cytokines like IL-10. So we know apremilast in adults is a 30 milligram twice a day dosing after starter pack. Laboratory monitoring is not required. Its efficacy is equivalent to methotrexate for patients who've been on methotrexate. And so you get roughly about 1/3 of patients achieving a PASI 75 clearance. It's not immunosuppressive. It does have wonderful efficacy in psoriatic arthritis. There are side effects, and about 20% of patients will experience diarrhea, nausea, and some vomiting, which is usually seen early on in the treatment course, and patients are able to move past that. But it can lead to loss of compliance. In a phase 2 open label study, apremilast was studied in the pediatric population with moderate to severe plaque psoriasis. So children between the ages of 6 and 17 were studied on dosing schedules to see how they handled different doses, and specifically the pharmacokinetic safety and efficacy of apremilast was studied in this age group in children with moderate to severe plaque psoriasis. And included in this patients had PASI scores over 12, they had over 10% body surface area, and they had significant psoriasis that was not responsive to topical therapy, and these were children who were candidates for systemic or phototherapy. So the apremilast study design looked at the 17-year-old age group, the 12 to 17-year-old group, with either apremilast 20 milligrams or 30 milligrams, and then they looked at a younger age group, 6 to 11, who weighed in at over 30 pounds, and they dosed them with apremilast 20 milligrams. They looked specifically at weights and included overweight and obese children, and we know that obesity is a comorbidity in psoriasis and can lead to early cardiovascular disease. So they looked at the effect on heavy children. These were children who had a significant PASI score in the range of around 15 to 20. So they had a lot of psoriasis, and they had it for a while. And we can see this plasma concentrations. The apremilast does get on board, and it peaks at around 3 hours and tapers off over 24 hours. The important finding in this study was the percent of improvement from baseline in all three of these groups. We saw anywhere from a 2/3 to almost 80% in decrease in psoriasis at week 16 when these various groups were treated with anywhere from 20 to 30 milligrams of apremilast. So this is very exciting and a very nice response with an oral medication with known safety. So based on this study, we're looking forward to them to move forward for an approval in children. So the study showed that weight-based apremilast dosing achieved exposure similar to that in adults. This is the first evidence of showing its potential efficacy in pediatric patients. And then the safety and tolerability profile was consistent with the adults receiving apremilast. So we look forward to bringing this drug to market for treatment in our pediatric population, particularly children who are more likely to take a pill than receive an injection. So I want to just shift gears a little bit about some exciting new developments in the treatment of psoriasis and psoriatic arthritis using pills that affect what we call the JAK-STAT pathway that in psoriasis and psoriatic arthritis. So the JAK-STAT pathway, particularly you can see here, there's a cytokine receptor on the surface of a T cell, and that signal, when this cytokine binds to the cytokine receptor on the T cell, that signal is transmitted to the nucleus of the cell for gene transcription through JAK1, 2, 3, or TYK2. And so let's take specifically a look at that. So here's an animation that shows on the left-hand side, you see the cell membrane and you see the alpha and beta receptors, and inside, just inside the cell membrane, we see two JAKs sitting there poised as a dimer, two of them hooked together. When JAK autophosphorylates, it in turn phosphorylates STAT, and then STAT travels to the nucleus after being phosphorylated and affects gene transcription, affects the DNA. And that leads to the production of mRNA and the expression of proteins. So when we have a JAK inhibitor, 1, 2, 3, or TYK2 inhibitor, we affect this pathway. And this pathway is very, very important for certain signaling at the cell surface through gamma cytokines, through IL-6 and interferon gamma, IL-23 and IL-12, and even cytokines that affect the hematopoietic signals. And this all leads to different gene signatures. But again, there's a lot of signaling that takes place through this pathway, and we're seeing the development of newer molecules to treat psoriasis, particularly as we look at the IL-23 and IL-12 going through TYK2 and JAK2, and IL-6 and interferon gamma also being inflammatory and going through that pathway. So what we know is that we have deucravacitinib has been developed. It's an allosteric TYK2 inhibitor, and we're going to talk specifically about that molecule, but importantly inhibits TYK2. And TYK2 is important right here. As you can see, it's part of the signaling pathway. And why is TYK2 important? Because if you're able to interfere or block TYK2, you affect IL-12, IL-23, and interferon alpha and beta that are drivers for psoriasis. And note that when you block TYK2, you don't affect the hematopoietic system or lipid pathway metabolism. So having a TYK2 specific inhibitor is wonderful. And there's a pivotal trial comparing deucravacitinib versus apremilast that just took place. And let me share this exciting results with you, that deucravacitinib is an oral selective TYK2 inhibitor. And you can see over here on the left, it binds to what we call the regulatory domain. It doesn't interfere with the catalytic domain that would cause some of the sort of cross-pollination and effect on some of the JAK1, 2, and 3 pathways. So this is very specific for TYK2. As a matter of fact, it's got 100-fold greater selectivity for TYK2 compared to JAK1, 3, and over 2,000 greater-fold selectivity for TYK2 versus JAK2. So that's important. So we have a very specific, very new allosteric inhibition. And this is important when we talk about impacting IL-12 and 23 and type 1 interferons that drive psoriasis. So let's take a look at the comparator trial between deucravacitinib, a pill, 6 milligrams a day, compared to apremilast, which we know is 30 milligrams twice a day. It's a pill. And note that at week 16, the primary endpoint, nearly 60% of patients achieved a PASI 75 using deucravacitinib compared to 35% with apremilast. And as you go on time, that number increases for the deucravacitinib up to 69%. And when we look at the primary endpoint in the second study, again, we're seeing very highly efficacious clearance in the neighborhood of 60% at week 24 for deucravacitinib compared to just around 40% for apremilast. So we have an oral systemic in deucravacitinib that appears in these studies to outperform apremilast. And we look at clear and almost clear. Again, we see deucravacitinib at week 16 and 24 having some very nice clear, almost clear data, with over 50% compared to 30% with the apremilast. And again, that holds up in the second trial, which compared both molecules. These are two parallel trials. When it comes to scalp psoriasis, we see some very nice results in clearance in both studies, with between 60 and 70% of patients achieving a clear, almost clear scalp psoriasis compared to apremilast. So we now know that this drug is very effective in scalp psoriasis and has outperformed apremilast for scalp psoriasis in these studies. And when we looked at adverse events in particular, there was no really significant safety signals with deucravacitinib or apremilast that led to discontinuation. And more importantly, with deucravacitinib, we really didn't see much in the way of the diarrhea and nausea the way we see in apremilast. So again, a highly efficacious drug that appears to outperform apremilast. Again, when we look at long-term safety, appears again to be very safe. And the signature for nausea and diarrhea and some headache was higher with the apremilast group. So it appears that deucravacitinib has a very nice safety profile, and there were no new safety signals observed going out a year with the deucravacitinib. And again, look at it comparing to a placebo. There were no AEs leading to discontinuation. There were any higher than placebo, actually quite lower than placebo. So this is really good news for this molecule. Of interest was whether deucravacitinib would inherit some of the laboratory requirements that we have to perform on JAK inhibitors to date. And because this is a specific TYK2 inhibitor, and it does not appear to interfere with any of the hematopoietic things like red blood cell count, white blood cell count, particularly neutrophils and T cells, nor platelets. When you look at the neutrophil count and platelets, there was no impact with deucravacitinib on either. There was no impact on total cholesterol or CPKs, which is a muscle enzyme. It appears that this drug really has no safety signals regarding these parameters, and the hope is that there will be no laboratory requirements on this drug. But we're waiting to hear from the FDA, who will weigh in on that when it comes time for approval. But to date, we've not seen any laboratory signals with deucravacitinib. So again, deucravacitinib is not yet FDA approved for moderate to severe psoriasis, but we've just completed the pivotal phase 3 trials. The data looks good. It appears to be very safe. Remember that it's a 6 milligram once daily oral medication that allosteric blocks TYK2, and due to, we believe, this unique mechanism, avoids affecting lipid and cholesterol and red cell and white cell groups, and the overall adverse events were similar to across all study groups. It was clearly superior to apremilast in comparator trials and clear and almost clear in PASI 75 levels, not just at week 16, but also maintained it through week 52. So we're looking forward to this drug. And just an FYI, the phase 2 data on psoriatic arthritis was very positive. And deucravacitinib had a very nice impact on psoriatic arthritis. So stay tuned. We're looking to have this as a dual threat, both for psoriasis, where it's likely to come to market sooner than psoriatic arthritis, but the psoriatic arthritis data looks very promising. So we have known for decades that we have to develop non-steroid topical therapies for patients with psoriasis because there haven't been any new or novel non-steroidal therapies in the last 20 years. And so we would love to have a molecule that avoided the issues with topical steroids. And we wanted something ideally that had great efficacy and tolerability, but avoided this topical steroid side effects, which we know are thinning of the skin and other side effects. So with that, we have 3 entries that are topical. They do not involve cortisone or steroids. They're categorized as whether PDE4 inhibitors, tapinarof, which is a new aryl hydrocarbon receptor agonist, and JAK inhibitor. So let's take a dive into these. So roflumilast is a topical PDE4 inhibitor, very powerful PDE4 inhibitor. You know, estimates are maybe 100 times more powerful than our current PDE4 inhibitors, and it's being investigated as a once daily non-steroidal topical treatment for various conditions, including psoriasis. And so in Dermis 1 and Dermis 2, these were 2 identical phase 3 randomized double-blinded vehicle-controlled studies of once daily roflumilast cream at a concentration of 0.3%. Were used to treat psoriasis patients. Here's the study randomized with roflumilast cream versus vehicle, and then the outcome measures were measured at week 8, and they looked at clearance and itch and PASI 75 scores. And very excitedly, I can tell you that the data in these 2 parallel trials show that when compared to vehicle, roflumilast in Dermis 1 and Dermis 2 had roughly 40% of patients with an IGA success of clear or almost clear, and the endpoints were achieved. And then when we looked specifically at these along with intertriginous areas, that's like the armpits, underneath the breast, in the groin, roughly 60% of patients achieved clearance in these folds. And the beauty is that there is no cortisone in this cream. It's a once daily application and very, very safe to use in those areas, including intertriginous areas. We look at areas achieving a PASI 75 score. Roughly 40% of patients in both studies achieved that at week 8. So we can see this very nice clearance. And here we see some photographs on the top panel. We see the knee at baseline and through week 8. And look at week 8. The scale and thickness is resolved. We have some post-inflammatory darkening of the skin, which we see at week 8 in all of our therapies after treatment of thick plaque psoriasis. But look at the axillary areas, the armpit areas at week 8, at baseline and week 8, clear. And this is really, this is wonderful. So we have a very powerful topical once-a-day treatment that does not have any cortisone in it. And you can see from these pictures that this is great efficacy. As far as any safety signals, this was a very clean molecule, and compared to vehicle, there were no safety signals. And if we look at diarrhea, there's a little uptick in diarrhea, which was pretty minimal, and usually around the 3% range in patients. Could this be related to the PDE4 known trigger for diarrhea and absorption? Possibly, but anyway, it's less than 5%. So not very common. I just want to shift gears to tapinarof. There's also a lot of buzz about this new topical therapeutic we call aryl hydrocarbon receptor modulator for psoriasis. And so it's a first-in-class, non-steroidal, meaning no cortisone topical therapy with a very new and novel mechanism of action for the treatment of psoriasis and atopic dermatitis. So into these 2 pivotal phase 3 trials that were just performed, tapinarof 1% cream applied once daily in patients with plaque psoriasis was evaluated. And so what is this about this aryl hydrocarbon receptor pathway? And so as those of you who are kind of geeky like I am and enjoy these little mechanisms, this pathway is what we call ligand-dependent transcription factor. And the aryl hydrocarbon receptor binds with a wide range of molecules, and it's found on keratinocytes, our skin cells, and other cell lines that have this receptor, and it has multi-functions on skin homeostasis and pathology. And this is the way it works. Once a ligand or molecule binds to this receptor inside the cell, it passes into the nucleus where it dimerizes, it combines with ARNT, and then that triggers gene expression inside the nucleus. And so this is the way it works. And then the proposed mechanism of tapinarof is a ligand. It binds to the receptor, translocates into the nucleus, and dimerizes with ARNT the way any ligand would, and results in gene expression. Well, what are those genes? Well, those genes are psoriasis and atopic dermatitis related genes. So let's take a specific look at this. So again, when tapinarof binds to this receptor and translocates in the nucleus, it decreases the Th17 cytokines, which decreases inflammation in psoriasis. That's what we want. It decreases inflammation, oxidative stress, and it promotes skin barrier improvement, and it decreases inflammation in atopic dermatitis. So this is a dual threat, a molecule that has no cortisone, and it's effective in psoriasis as well as atopic dermatitis. So in the trial, they had two parallel trials comparing tapinarof once daily application for 12 weeks versus vehicle. In this randomized trial, most of the patients had moderate disease, and the body surface area was around 8 to 9%. And when we look at the results, we see a PGA response, a mean treatment success of around 35 to 40% compared to 6% for the vehicle. And when we look at PASI 75 scores, we see roughly 36 to 47% achieving a PASI 75 compared to 10% or less for the vehicle. So this is a very powerful topical molecule. And here's a pictorial. Here we see baseline, week 4 and week 12. Here we see at baseline, the assessment was a physician's global assessment of 3, and then look at that clearance at week 12. So very powerful molecule, once daily. And when we look at side effects, we look at patients with folliculitis, one of the known side effects, and these are kind of like not infectious folliculitis. These are little bumps, and it's a side effect of the medication. And we see it mild to moderate and mildly in about 2/3 of patients, half to 2/3, but maybe a third will have some moderate, but severe 1% or less. And so really it's just a side effect of this drug. These are little tiny bumps. But again, we have to weigh that against the efficacy of this drug. Rexolubnab, we were talking about JAK1 and 2 inhibitors in a proof of concept study. It worked very well as a cream. And they did this dose ranging study of once a day and twice a day. And Rexolubnab was very effective and appears, at least in all the studies, to really work well in psoriasis and may represent a new treatment down the line. But currently, there's no plans to move forward. But know that this may move forward. And we'll have, again, another non-cortisone containing cream for the treatment of psoriasis, particularly local psoriasis. So generalized pustular psoriasis, this is a very serious disorder characterized by patients with fever and chills and temperature. They look quite toxic. The skin is red and inflamed, has pustules and scale. We understand that through research that IL-36, interleukin 36, is involved in the pathogenesis of this disorder. Here's one of my patients who had been on systemic steroids. She was treated by a general practitioner with monthly injections of cortisone. The doctor disappeared, a non-dermatologist, and then this patient found her way into the hospital and under my care with pustular psoriasis, a flare from being abruptly withdrawn from systemic steroids. And so we have the development of this monoclonal antibody against IL-36 receptor, and it blocks IL-36 signaling, and it's called spesolimab, and it's an IL-36 receptor antagonist. In this proof of concept study, an intravenous infusion, one single infusion, and an open label study had a remarkable result. And here we can see the results of 6 patients who their scores basically went to 100% clearance, as few as like 2 doses, and certainly within the first month. And so we can see some pictures here at baseline. You can see the scores top and bottom. And at week 1, look at this dramatic response. And in week 4, these patients are really effectively clear, almost clear, after a single infusion of this drug. So preliminary results show, at least in 5 patients, at least 3/4 of them achieved 75% clearance at week 1, and all patients were clear at week 4. And so they move forward with this drug in general pustular psoriasis. Well, when we talk about generalized pustular psoriasis, we also bring into mind palmoplantar pustulosis or pustular psoriasis, the palms and soles, which can be very debilitating. And I know this is a very busy slide, but if patients with this disorder really have a tough time, both grasping things and walking. And so they decided to study plantar pustular psoriasis with this medication. They did a randomized trial with placebo, low dose 300 milligrams, and high dose 900 milligrams. And they used a scale to measure the severity of disease. And then the patients had significant palmoplantar pustulosis. And I know it's a very busy slide, but patients had this disease for roughly anywhere from 7 to 10 years. And at baseline, there was very significant disease. And roughly most of these individuals were females in the study. Unfortunately, when they did the severity index scores measured over week 16, there was no definable outcome measurement that showed it was any better than placebo, certainly at week 16. But when you start data mining this and look at the pain scores, you realize that for patients with severe painful disease, that the drug did outperform at the higher dose, the placebo. And I think that's very important to note. And so as far as this pilot study, the primary endpoint, at least a palmoplantar pustulosis score at week 16 was not met. However, this may be due to the small sample size or primary endpoint. In some patients, this might coincide with the natural waxing and waning of these lesions. But it's important to note that patients with more severe disease appear to respond better. And what we do know is that the treatment with the higher dose was associated with a rapid reduction in pain, and they're looking at additional doses. And so they're moving forward with the phase 2B proof of concept study. So this is exciting for patients with palmoplantar psoriasis. So with that, I know I've done a very tour de force, data-heavy presentation, but I feel that if you are suffering from psoriasis or psoriatic arthritis or have friends or family members who suffer from it, then I wanted to present really the hardcore data, and you could really see for yourself and take time to review this lecture. And I want to thank you and the National Psoriasis Foundation for letting me spend this time with you. And as we say in Hawaii, mahalo, meaning thank you, and aloha means goodbye.
Well, thank you, Dr. Martin, for providing such an amazing research update. It's exciting to hear the new developments and treatment options. So much is occurring in the field of psoriasis and psoriatic arthritis. So it's now time for a Q&A portion of this webinar. Dr. Martin, our first question, does IV infusion work better than a cutaneous injection?
Well, we've shown that intravenous infusion certainly gets the drug into your system quickly. And infliximab, I think, which we also call Remicade, is the hallmark of that. But over time, what we've realized is that subcutaneous injections of the biologic agents really results in a very quick and rapid response and very predictable response. So you're really not losing anything by going subcutaneous injection. And pretty much every one of our new therapies in psoriasis are subcutaneous injections.
And what's the relative risk of different types of biologics and the targeted pathways over the long term?
So the medications that we've developed over the last several years are really targeted therapies and in large part involve the IL-17, IL-23 pathways for generalized plaque psoriasis. And there's incredible safety and durability of our current molecules. And so that's where we are today, that we're able to control this disease. And as you've seen, certainly from the Bimikizumab data, and if you're familiar with the other data from the IL-17s and 23s, anywhere from 40 to 60% of our patients achieve a complete clearance, and it's a durable clearance. And so that's exciting. So yeah, we have durability with these new molecules over time.
What about, is there any hope for people with fingernails that are cracking and separating?
Yeah, if your fingernails are cracking and separating and there's evidence of psoriasis underneath your nails, that's your psoriatic disease. And clearly what we know are two things. If you have psoriasis of the nails, which we feel is due to inflammation, not just of the underlying skin with psoriasis, but also the entheses, the insertion of the tendon into the bone. If there's inflammation there, that can lead to obviously nail dystrophy or psoriasis of the nails. And it can also be a marker for underlying psoriatic arthritis. So if your nails are cracking and splitting, you have psoriasis under the nails, you look for signs and symptoms of psoriatic arthritis, morning stiffness and pain in your back and tenderness and swelling of your joints, not due to trauma. And so it's important to think about that. And the good news is that pretty much all of our newer therapies particular high-performance biologic agents, are very effective at clearing up nail disease. And if you're one who is interested in taking an oral medication, say a Primulast is also very effective at treating nail disease.
Great. And you covered a lot of information today, but we didn't hear much about biosimilars. Can you provide an update on biosimilars, and are there any being used today?
Well, in the field of psoriasis, we do not have any biosimilars that have been approved in the United States. We're certain that they're coming. We've seen the studies, and they are in fact similar in their results to our current therapies. And I think the other parts of the world, as well as other areas, for example, psoriatic arthritis, where we have generic infliximab infusions, we're seeing the entrance of biosimilars into the field. So with regard to psoriasis, they're coming. Whether this will affect the price points or not, I'll be anxious to see.
Okay, and you mentioned a little bit about the mRNA. What role will mRNA treatments play in the future?
So I wasn't quite certain if they meant mRNA vaccines. So we know that the Pfizer Moderna vaccines are mRNA based, and they open up an entire new therapeutic realm as far as vaccine technology, because once you identify the sequence of a virus, you can then turn around and create mRNA strategies to target the virus. So that's very exciting. As far as mRNA pathways in psoriasis, there's quite a bit of research that's taking place in the realm of mRNA analogs to impact the disease. So it's still at the basic science research level, but I think there's mRNA technologies that are being explored.
Great, thank you. And any definitive explanation yet for what causes and triggers psoriasis?
You know, when I went over the early slides looking for the holy grail, that's the autoantigen. And we talked about LL37 and DAMPSL5 and, you know, the lipases and keratin 17. We're starting to think that trauma to the skin, mechanical trauma, skin infections, staph, candida infections in the intertriginous areas start triggering this inflammatory process by the creation of these autoantibodies against our normal skin proteins, or proteins that get exposed upon trauma that then become a target for our immune system, which normally is very tolerant. But when intolerance develops and these molecules present in our skin are perceived as invaders, as non-self, that's when this whole autoantibody thing takes place that can drive psoriasis. And so we look forward to continuing research in the area of how this whole process gets started and identifying biomarkers for measuring, is this disease real and present? And can we predict the course of the disease? Can we intervene with therapies and halt this early on? So we're really on the cusp, I think, of finding a cure. For now, we have great therapies that are able to create sustained remission.
This is a great segue into my next question, and you feel that we're on the cusp. How close are we to finally finding a cure for psoriasis?
The $1 million question. And speaking of $1 million, please give generously and freely to the National Psoriasis Foundation, because they are really supporting scientific research, looking for a cure. And that's really what we all want. How far away are we? Obviously, we're closer than we were. And with all the advanced tools we have, it's really, it's impossible to predict. But I think we're, you know, in the next decade, we're going to see some remarkable advances, which, listen, I've been treating psoriasis for 35 years, and I was back in the day with topical steroids and TARs and light and methotrexate, and look how far we've come in 35 years. Matter of fact, look at where we've come over the last decade as far as therapies, very powerful, very targeted therapy. So I can only believe that in the next decade, we're really going to unravel some of the mystery of what triggers psoriasis and have some interventions.
Well, that's a great sense of hope to end our webinar today on. Thank you, Dr. Martin, for your time and efforts to answer the many questions we received, and for providing this presentation with truly the latest information about psoriatic disease for our viewers. We're grateful to you for sharing your expertise about inflammation associated with psoriatic disease, current and upcoming treatment options, and lots of new options for the future. That's Terrific. Thank you.
Well, thank you, Bev, and thank you to the National Psoriasis Foundation. And I look forward to chatting with you sometime soon.
Okay, thank you. In addition to today's webinar, podcasts are also available through Apple Podcasts, Google Play, Ghana, Spotify, iHeartRadio, or a feed service of your choice. Access podcasts at the website listed here. If you'd like to hear more about research updates, listen to episode 140, The Hunt for Genetic Signals in Psoriasis and Psoriatic Arthritis, with dermatologist and geneticist Dr. James T. Elder, which was just released, or episode 136 about gut health, also known as the microbiome, from rheumatologist Dr. Jose Scheer from NYU Langone Health. August is Psoriasis Action Month. During August, receive the latest information about managing psoriasis and treatment options via email through the Advance e-News. If you're not receiving the e-News, subscribe today at psoriasis.org. Connect with others on Facebook, Instagram, and Twitter to engage in our Q&A series about the types of psoriasis. During August, order your Psoriasis Action Month kit about types of psoriasis. To order your kit, contact the Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Navigation Center to ask about connecting with others through the one-to-one program. Reach out at education@psoriasis.org or call 1-800-723-9166, option 1. Thank you again to our sponsors, Amgen, Bristol-Myers Squibb, Janssen Pharmaceutical Companies of Johnson & Johnson, and Novartis for their support of today's webinar. Finally, don't miss our next live webinar, Q&A about scalp psoriasis, next Wednesday, August 18th. You can register at psoriasis.org/watch-and-listen. You can also access today's webcast and other past presentations in our webcast archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for attending.